Good morning. My name's Yasmin Hernandez-Barco. I'm from Mass General. My colleague here will introduce himself.
I'll introduce myself. I'm Steve Pandal from Los Angeles at Cedars-Sinai Medical Center. And Dr. Barco is going to start the first part of the session.
So we'd like to welcome you. This is a session called Innovations in Early Detection of Pancreatic Cancer, and we'll be focused on exciting translational discoveries, both in the machine learning space, development of biomarkers. And I'd like to introduce our first speaker, Allison Klein, who's a professor at Johns Hopkins, and she will talk about the genetic epidemiology of pancreatic cancer, recent innovations in an evolving landscape.
Thank you so much for the invitation to be here. It's a pleasure to be here with all of you. So I'm going to give you a little bit of an overview. I have no ability to move my slides forward or disclosures. Okay, hopefully that will work. So, there we go. So why do I study the genetic epidemiology of pancreas cancer? We know, and many of you know, how important genetic risk factors are. There's a growing list of both low risk and higher risk variants. Inherited risk variants can inform who we should screen, and we've really seen that change over the past 20 years by the work of Mike Goggins and Mimi Kanto. And some germline variation have treatment implications. So when I think of the sphere that is pancreas cancer, we know that about 10 to 15% of patients report a family history. We also know that about 30% of pancreas cancer is heritable. There is overlap in those two, but we also know that there's distinct. There are some families with a family history who just might have an aggregation of other risk factors. We also know that for many of these, even the high-risk genes, penetrance is low, so we don't always observe a family history. We only know the genetic changes that explain about 4% of this, so there's a considerable amount that we still need to uncover. So at Hopkins, now I'm going forward too fast. So I run a family registry of about 8,000 families with pancreas cancer. About a third of those are familial, which is two close relatives of pancreas cancer. So while, as I said, we know some genes and screening individuals with high-risk genes is really important, family history can still be a meaningful risk factor. We recently published our follow-up of some of these families we've been following for 25 years. We continue to accrue new families. We follow up with them about every year and ask them about new cancers in their families. Other habits have changed. And what we've seen is a remarkable increased risk of cancer. So in our familial cohort, we have over 110 new pancreatic cancers. We also see these in individuals who join us with just one pancreatic cancer in the family. We denote these as sporadic kindreds. And we also ask about spouses as a control measure for unrelated individuals. Using kind of competing risk models, we published cumulative risk estimates, so lifetime risk in these individuals, conditional on family history. And what we saw, in addition to family history, the age of those family members are important, with younger onset, so cases before 50, those families having higher risk than when we just have later onset families. And what we see here is kind of a remarkably high risk with when there's 3 first-degree relatives, about a 25% lifetime risk by age 85, decreasing to about 7% with just 1 first-degree relative. In the younger onset, a little bit lower, about 17-fold, versus 17% versus 25% when we look at late onset kindred. So both are important. Young onset is even higher risk, and this is true whether or not there was an excessive family history or not, or just a sporadic case. What we really have is kind of a spectrum of risk, though. We have the very high-risk genes, and we have lower-risk genes as well. In the high-risk space, as I mentioned before, in our circles, there's overlap, with the pie chart on the left being those with a family history, and those on the right without a family history, and the relative contributions of the genes we know about. BRCA2 being most common, then ATM. And what we know, it's the same genes in both the familial and non-familial forms. We've done studies in the past looking at the cancers. The cancers are also very similar. But we see it's just more likely to have a test positive if you have a family history than a not. But there is this considerable, over 80% of the familial, where we just still can't explain. Anna D'Souza Costa and Florencia McAllister out of MD Anderson and Johns Hopkins recently published a study where they looked at patients with PNETs, so not our adenocarcinomas, but the neuroendocrine tumors. And we also find, again, this similar story, a high risk of pathogenic variants in the higher risk families. So these are families seen at a high risk clinic. 33% had pathogenic variants in a hereditary cancer panel. About 15% had MEN1. Not surprising, but we also saw 6% had defects in DNA repair pathway, and about 2% had MSH2 variants. In a unselected cohort from Johns Hopkins, 21% had pathogenic variants, 8% had mutations in DNA repair pathway, and 8% in MEN1. And those with a identifiable germline predisposition were more likely to be multifocal, and have a lower risk of onset. For adenocarcinoma, what is the risk associated with these genes? Again, many of you know it's up to 7% for BRCA2, about 7 to 8% for ATM. The rare and common variant space, but in addition to that, we also need to do better in GWAS. Our GWASs are small compared to other diseases, so again, we're more than tripling the size of the GWAS for these studies. We're kind of in the weeds with just starting with the data analysis on it, but we really hope to have some new exciting information kind of coming up. The other avenue we're pursuing is long read sequencing. So most next generation sequencing is short read, so short fragments of DNA. Tremendously powerful, but it's also hard to resolute larger structural variants. So insertions, deletions are harder to find. So together with some of the leaders in this technology, Mike Schatz and Winston Timp, we got a grant funded to do long read sequencing of over 400 familial pancreas cancer patients. We originally included families from Steve Gallinger's group, and Gloria Peterson was a valuable collaborator. Unfortunately, she passed away, but her team at Mayo Clinic is really committed to kind of continuing and having these studies for her, and it's really in part because of the resources she's developed. So that's really kind of where we're headed, and hopefully we can kind of uncover a bit more of this space and provide some more answers to these families soon. And this is really, everything I do is because of team science and having a great and wonderful team and group of collaborators to work with and really move this forward. Here are just some of them, but really it's how important this is to really work with others on this. Thank you so much.
I think we have time for a couple questions.
So Atur Singhi, excellent talk as always.
Thank you.
One of the things I'm always struck by is the large amount of the pie that we still don't know. And is the answer really maybe something else, not necessarily completely germline, but could it be mosaicism? Because I've never heard of pancreatic ductal adenocarcinoma or pancreatic cancer as we know it associated with mosaicism. Yet we know that other types of neoplasms can, like VHL,
Right.
can be mosaic. Do you think that maybe the other portion of the pie could be mosaicism that we just haven't been able to pick up based on traditional germline sequencing?
I mean, I wouldn't rule anything out. I mean, I think what's hard is there might be a segment that might be mosaicism. We haven't really looked. We have done some, sometimes when we sequence, we use duodenum, we use normal pancreas, but sometimes that normal pancreas isn't as normal as you think, and it's hard with a lot of these technologies to also use FFPE, which is what we're stuck with too. We actually saw the opposite. In a sense, when we were looking for the whole genome sequencing study, is that we saw a couple of mutations in blood, and then we went and looked in the tissue, and they weren't there. One was in TET2, and it ended up being clonal hematopoiesis. So we were all excited, and then at the same time, all the colonal hematopoiesis came up, and we're like, yeah.
Thank you so very much.
Thank you.
So now we have the pleasure of the presentation by Dr. Beecham Wu from Southern California Kaiser System. And the title of his talk is Mining the Electronic Health Record, EHR, for Early Detection of Pancreatic Cancer from Virtual to Reality.
Thank you for the introduction. I'm very grateful to be here and also appreciative of the organizers for really hosting this important session. I hope it becomes an annual tradition. So I do have disclosure. It's unrelated to any of the topic for today's discussion. And first, I would start by pointing out a reminder of the USPSTF recommendation against screening for pancreatic cancer, grade D. This kind of reminds me growing up in middle school, some of the report cards I would receive. But I will point out that they gave us an exception, and this sort of reminds me of has promising potential as a middle schooler. And that is that it doesn't apply to those known to be at high risk of pancreatic cancer. So everything that we're talking about in this session is within those parentheses. So I think that's important to remember, that the USPSTF gave us this opening. I'm very grateful for many of those in the audience who helped lobby to have this statement. I think it's helpful at the outset to think about a taxonomy for approaches to early detection. And by the way, you can trust this because I did validate it with ChatGPT. So screening, a process of using a medical test or procedure on people who don't have symptoms of a disease to determine their likelihood of having it. That's what the USPSTF is referring to. Surveillance, the ongoing evaluation of a patient who has a disease that appears to be stable or not progressing, and here we could think of your IPMN, or someone who has an increased risk of developing a disease. And this would be those high-risk individuals based on germline or familial history. When we think about the EHR-based approaches that I'll be describing to you, we can think of these more as an early warning system. Right? It doesn't necessarily fall into screening or surveillance, because what this entails is an organized mechanism to rapidly detect and respond to signals that might indicate potential underlying disease. So it's a bit of a different framework than the traditional screening or surveillance paradigm. And how can we conceptualize this? Why would this approach even make sense? So there have been several cost-effectiveness studies looking at targeted approaches to early detection. I've selected those that refer to new-onset diabetes because that bears a similar framework, that it's an early warning system. It's really a 3-year period of risk. We're not talking about new-onset diabetes being an indicator for lifelong surveillance. It's really an indicator of underlying prevalent disease that may go undetected otherwise. There have been at least 2 cost-effectiveness analyses in this space. What they determined was that at the $150,000 threshold per quality-adjusted life year, the threshold of 1% risk at 3 years was cost-effective. If you go down to the $100,000 per quality, a 2% risk was over that 3-year period was deemed to be cost-effective. And in another meta-analysis, one of the parameters that was determining the sensitivity of a cost-effective strategy was related to the number or proportion of screen-detected cancers that would be resectable, and that $100,000 threshold is at least 25% of screen-detected cancers. This is very helpful. Why? Because now we have some goalposts as far as if we're going to develop a strategy that looks at the EHR model, implement that, these are the types of numbers we're thinking about to have a cost-effective strategy. If we know with DOD, approximately 20 to 25% of the pancreatic cancers will have that as a precursor. But what about if we look at the EHR? What is the potential of EHR early detection? This is a question I ask. Dream scenario, what's the ceiling? How many patients could we possibly identify? Because let's face it, even though there may be members within the health system, they're not all accessing the system, right? So we need to have patients that are engaged in interacting with the health system. So to answer this question, we did a quick look to see how many patients in our system developed pancreatic cancer between 2008 and 2023. 2008 is when we initiated the electronic health record, and that number came out to just over 11,000. Now, how many of these patients had at least 2 outpatient visits with a provider in the 6 to 36 months prior to their pancreatic cancer diagnosis? 94%. Okay, but that's not enough, because the question is, maybe you're just seeing your doctor because you're feeling sick and you have symptoms of pancreatic cancer. What if we take this out further? We looked at the intensity of visits in that 6 to 36 month period, and that's what this figure shows. On the horizontal axis, we broke it down by the time window in terms of prior to diagnosis, and then the average number of visits within those specific time windows. And excluding those 6 months prior to diagnosis, even in those 6 to 36 months, on average is about 5 visits per those intervals, indicating that we have a chance to really identify these patients because they are interacting with the health system even well before they develop pancreatic cancer. That's the promise. Let's look at the reality as of 2024. So I call this the reality because this is what we've been able to do in terms of our homegrown EHR prediction model. On the left, you see the performance results from Kaiser Permanente, Southern California, and then a validation at the Veterans Affairs. What I draw your attention to is the positive predictive value. This is, when we run this retrospectively, the number or proportion of cases that we anticipate to find. And even in the upper echelon of these models, it tops out at around 1% in our data, somewhat higher in the VA. And that's understandable because their background rates of pancreatic cancer are higher than what we see at Kaiser Permanente. But to anchor you, if we just looked at our reference population over this was an 18-month interval in terms of the predicted risk. In the general population within KP, it would be about 0.1%. So we're talking about a 10 times enrichment. That said, we're not capturing all the cancers through this approach, and so if we use that threshold, it's about 20% of the pancreatic cancer case that we'd be able to identify. Of course, we'd be able to identify many more if we move leftwards and relax the criteria, but then there are many more patients that would need to be screened. This is what I call the floor. Not because I don't have faith or confidence in the rigor of our approaches, but the fact that this is 2024 and this is a model that we've already established. If we do a search of PubMed looking at prediction models for early detection of pancreatic cancer, we've seen an explosion. So in 2023, 69 articles. Now, you might wonder, well, are all of these really what we're talking about? Is there that many studies coming out? Well, we have some data from 2 systematic reviews now looking at prediction models in pancreatic cancer. First came out last year, and it's interesting, 2023, that sounds like ages ago at this point. So this was a study looking at prediction models. They found 33 studies evaluating 38 models, 8 with external validation, and they broke it out by models looking at diabetes status, general population, or asymptomatic populations, and they achieved AUCs in the 0.61 to 0.98 range. And then a very recent systematic review that was published online by one of our subsequent speakers, they looked at specifically machine learning models within the electronic health record. They identified 30 studies on this topic, 9 models with external validation with AUCs of 0.57 to 1.0. So what you can see is that there is really a massive growth in the number of models that are being produced, and whenever we see this, there's a framework typically that develops, and this is one of those, the tripod statement. I've included the website. This is from the Equator Group, the same group that gave us the consort framework as well as strobe reporting guidelines, and this is just one of those domains when they talk about development, validation, and updating of a prediction model. It's very important to think about how are the models being validated. Is it internally with a set-aside, or is there a completely external data set? And so that's a way to help assess some of the rigor of the models that are being developed. But let's zoom out further. Let's take a look at this landscape and say, where are we as a field in terms of the development of AI pathways? And I think it's useful to draw a parallel to drug development. All the work that's being done is really akin to preclinical trials. It's our experimental models. It's in silico. And the question is, what are the steps that we need to really move this into clinical practice? So one of the unique features about some of these EHR models is that before moving them into actual clinical application, there is the opportunity and in fact the need to run them in a beta form. So you run it passively and really tweak the model, see how it's performing, whether it's performing to expectations in the health system. Followed by, there's an early live clinical evaluation. This is akin to a clinical phase 1 or phase 2 trial where it's a pilot study. You're not running it in the entire population, but really seeing how it performs with an intervention. And then there are larger scale studies such as the comparative prospective evaluation, and then the parallel to the post-market surveillance would be this concept of vigilance. Sometimes I feel like this, though, that if we build it, will they come? I feel like the Iowa farmer that's building the baseball diamond in their backyard. How do we take this, build the infrastructure, and then actually see if our mythical baseball players will show up? And so there are a few examples of this. This is the Regard study presented yesterday. This is a nice example of that passive model in action. And so this was a subset of the New Onset Diabetes Consortium, 4 health systems, 2 in California, 1 in Minnesota, another in Texas, collaboratively developed and applied an algorithm for new onset diabetes based on glycemic factors. And this was, while not a full-on artificial intelligence machine learning algorithm, those of you who have worked with Dr. Char in the audience know that he is very demanding in terms of these algorithms. And so it was an opportunity to work collaboratively across these different health systems to develop an EHR algorithm. It was applied in real time. There were almost 19,000 eligible patients that were identified. The median follow-up was 2.3 years in this interim analysis, and there were 82 cases of pancreatic cancer that were identified. Those of you that follow the literature closely will see that this number is significantly lower than what was initially reported in some of the Mayo data, but part of that may have to do with a variation that we saw with respect to race and ethnicity, such that in the non-Hispanic white population, the actual observed rates of pancreatic cancer were very similar to what was observed in the initial studies. However, other racial ethnic groups did not have that same degree of incidence based on glycemically defined nod. What about early live clinical evaluation? Well, that's something we've done at our institution. We piloted an approach applying our full electronic health algorithm and enrolled 102 participants. Everyone received MRI, and we found one very early case of pancreatic cancer in this setting, kind of showing that, yes, this can work. And interestingly, it achieved exactly the target, what we anticipated, that 1% positive predictive value. But there's still remaining questions for how we transition EHR models to the real world. First, what is the target level of performance? And I would submit that as someone who's focused on implementing and applying these models, I'm interested in the positive predictive value and correlate to that the false positive rate. Our cost-effective analysis suggests that a 1 to 2% threshold should be sufficient. That said, you're still doing 99, 98 scans for every one cancer that you're identifying. In reality, I think we can do much better than that. Our target should be in that 10% positive predictive range. 9 false positive scans for one cancer detected. I don't think anyone is going to argue with that as being a valuable strategy. But how would we achieve this? How would we expand or improve on our performance? Well, that's where we would add a biomarker in addition to that first stage of electronic health record testing. And what target do we look for? Well, if we could identify 25% or more early stage diagnosis through this approach, I think we've reached our benchmark. And many of you in the audience, including those in the outside space, will say, this is really far off. How can we even think that a biomarker would be able to perform? Well, we have CA19-9. It's been around for decades, and this was a very nice study conducted using the PLCO cohort, looking at 129 resectable pancreatic cancers compared to 275 controls. These were pre-diagnostic samples that were evaluated. And this is the data from CA19-9, and what you can see is that the area under the curve, the prognostic ability, starts to really improve in the 2 years prior to diagnosis. The challenge, though, is that when you take it that far out, at 2 years, the sensitivity is only in the 12.5% range, and even 1 year out, 27%. So we're really not at a point where CA19-9 by itself is sufficient, but it does show us a way forward. And then along these lines, when we're applying these models, it's not just applying the models and going home. It's really, we have to develop an entire workflow around how we're going to not only identify the patients, to assign them for further detection, if they have a biomarker, whether it's CA19-9, an additional marker, how do those results get incorporated into clinical practice? Where are the cutoffs going to be? What prompts a CT scan, as well as how are those results managed? And this really requires a team-based approach. And then revisiting another concept that I think was highlighted in the REGARD study, building in concepts of equity from the very start. This is really a field unto itself at this point, talking about algorithmic fairness. How do we ensure that the prediction models that we use are not simply exacerbating disparities that we see? And so this is entire literature, but there are ways to improve the fairness of the algorithms based on a number of different dimensions. And then finally, what is the framework? Is it a best practice alert for early detection? And many times you'll see this in studies or talks. Let me just provide some reflection about best practice alerts. We have over 1,320 best practice alerts that fire 3.2 million times each week in our health system. Almost 80% of these are canceled or overridden. So just developing a best practice alert is not sufficient. So how would we actually go about this? This is crossing over to some of the health care delivery sciences, but a large-scale safety and effectiveness paradigm. There's an implementation aspect to this called REACH. It includes REACH, effectiveness, adoption, implementation, and maintenance. And so really, there's an entire field devoted to how we would actually scale up and sustain this type of a strategy. So I'll wrap up now just by summarizing. I think for the preclinical and in silico model development, we've reached a critical mass. However, the journey to real-world application is not trivial, and I've shown a picture of an airline because we all know how challenging it is to catch our flights and leave on time nowadays. But also, there's a plateau with respect to the positive predictive value. That just the EHR alone is not going to be sufficient. The models can certainly be improved with incorporating germline testing, but also blood-based biomarkers, radiomics, augmented EUS. What's very encouraging is that we've seen multiple abstracts on each of these domains at this very meeting. In addition, equity needs to be considered at the outset, and then finally, vigilance is needed to ensure uptake and maintenance for ongoing success. And I'll conclude with the acknowledgments. I think similar to what was stated earlier, these types of initiatives really require team-based science. And so they're very grateful for the team at Kaiser Permanente Southern California. I would call out Wansu Chen, who's been my longtime collaborator and spearheaded many of these efforts, but then also both in California and around the country, the collaborators who have contributed to this work and ongoing collaborations. So. And our sponsors, funders, NCI, and Pancreatic Cancer Action Network. Thank you.
Thank you so much, Beecham. His talk is open for discussion. So I'll start here, Beecham. So what's your timeline? When do you think you could start actually identifying patients that one could consider entering maybe prevention trials?
So I think first the early detection, and then I think that does feed into this concept of potential prevention as well. It's hard to have the timeline. I would say probably in the next 5 years. So we've done the pilot work. Our plans are to expand this to a much larger cohort. That's where we want to partner with outside groups to try to enrich the strategy. But there is this lingering question in terms of prevention. It becomes, if we identify a high enough risk group and we don't find the cancer, right? If there's not a cancer, our signals are showing that there's a molecular assay that's indicating there's an individual at higher risk. Our algorithms are saying they're higher risk. We can't find a lesion to take someone to cancer. What should we do in that situation? That is an ideal scenario, I think, for something such as chemo interception.
Would it be something like treating high blood pressure, where some patients are going to benefit but others don't, but everybody has their blood pressure controlled?
Yes and no. I think that it's not that everyone would have blood pressure control. It's we really narrow the field in terms of those that have an elevated predicted risk.
Got it. Dr. Chari?
I enjoyed the talk, and we've been on this journey together for a number of years now. And I was intrigued by the last piece you said about the best practice alert, which obviously is disconcerting to see that everybody wants a best practice alert, and soon it becomes meaningless. But when you're coming up with an idea like this, which is going to be different from the PCP's normal way of functioning, how do you then go to the next step of getting that done in real world? If it's not going to be, if the best practice alert is not acted upon, how else do you get it to work?
Great question, Suresh. And so I come at this from a health system standpoint, and pancreatic cancer is not the only area where this is being applied. So an example would be in breast cancer, where radiomics is being applied, and there are modules for this. And what we've done is actually take it off of the primary care provider's plate. That there is a safety assurance program that's in place. There are patient navigators who will act based on those findings and really be able to identify the patients, contact them, and walk them through that testing process.
I felt that would be the way to go, and that somebody else will be in charge of taking this forward rather than burdening the PCP with it. But institutions have to agree that that's worthy of investment of personnel in that effort.
Got it. Okay, thank you so much, Dr. Wu.
So I'd like to introduce our next speaker, Dr. Shunak Majumdar from Mayo Clinic. He's the director of the Pancreatology Fellowship and professor of medicine. And also perhaps, just in the interest of time, our speakers could always stay a little bit after the session if there are additional questions that we don't get to. And he'll be speaking, on methylated DNA biomarkers in pancreatic juice for pancreatic cancer detection.
Good morning, everyone. I do share Beechen's enthusiasm about a session on early detection every year. And it's wonderful to see everybody come together on this rather challenging but really impactful problem. I'd like to thank the AGA for the opportunity to share with you all our work on methylated DNA markers in pancreatic juice as a diagnostic tool for pancreatic cancer. As you heard from the previous speaker's talk, there's a lot of effort on risk stratification. And once we enrich the population, we'll still need novel tools because it's not easy to diagnose pancreatic cancer at an early stage. Here are some of my disclosures that are relevant to the talk today. So let's look at the pancreatic cancer problem. Several of you in the room already know that out of the 66,000 patients that we're going to diagnose with pancreatic cancer this year in the United States, more than half of them will be diagnosed with metastatic disease with fairly dismal outcomes. And the 5-year survival of this disease has increased over the past few years, but it's still a low number, about 12 to 13%. And of them, if diagnosed with localized disease, which is less than 15% of all patients, that 5-year survival goes up to 44%. I think you'll hear later in this session that for screen-detected pancreatic cancers, that number can be even higher, reaching 60 to 70%. So there's an opportunity to enhance our tools for early detection and get at the disease at a stage where it's potentially curable. So if you're talking about screening, pancreatic cancer, like any other cancer, goes through stages of low-grade dysplasia and high-grade dysplasia before turning into invasive cancer. And this applies to both cystic precursors of the disease as well as pannin lesions that are broadly categorized into low-grade and high-grade. And the ideal biomarker, while it's really good to detect asymptomatic early-stage cancer, but really the ideal biomarker, you would want to intervene at the stage of high-grade dysplasia, detect patients with advanced neoplasia, and hopefully intervene and prevent the disease. So many of you are familiar with the term liquid biopsy. There's been a lot of work in this domain, more so in the last 5 years or so, that relates to assaying cancer-related material from a blood sample. It could be nucleic acids, could be proteins, and several other products. But we and others, when exploring this space for blood-based early detection, have recognized certain challenges in our own work with methylated DNA markers. While a set of markers can detect cancer in a blood-based assay with more than 90% sensitivity and specificity. These blood-based biomarkers are typically unable to detect advanced precancerous lesions and generally have a lower sensitivity for the early stage cancers. And you saw some data on serum CA19-9. This has been a biomarker that's been available in clinical practice for several decades now. There are limitations to using it for screening purposes, which is why it's not used in the context of screening and early detection in the clinic. So we kind of shifted our attention a little bit to pancreatic juice as a potential more proximal biospecimen for detection of pancreatic ductal adenocarcinoma. Adenocarcinoma starts in the pancreatic duct, and exfoliated neoplastic cells in pancreatic juice thereby provide an opportunity to not only get at really early stage cancers, but maybe even be able to detect high-grade dysplasia. And the question is pancreatic juice a viable biospecimen for early detection? So if you look at the current paradigm of screening high-risk individuals for pancreatic cancer, it relies on MRI imaging and endoscopic ultrasound. Typically, an abnormal MRI results in a diagnostic endoscopic ultrasound. And screen-detected indeterminate lesions in this context pose a major diagnostic challenge. We know that the sensitivity of USFNA is low, and oftentimes this leads to inadvertent surgery and other suboptimal outcomes. More so, pancreatic juice can be collected during a routine upper endoscopy and definitely during an EUS. It adds approximately 5 minutes to the procedure time, where the juice is collected from the small bowel with secretin stimulation similar to what you would do for a secretin MRCP. And there's really no need to cannulate the pancreatic duct. And so there's some feasibility, and it appears to be a good fit if it has high diagnostic accuracy. So this was our hypothesis, that juice biomarkers will enable detection of both high-grade precursors and early-stage ductal adenocarcinoma with high analytical sensitivity and specificity. And I'll share with you a sequence of studies we did subsequently to explore this hypothesis further. So the first was a tissue discovery, and here we were trying to look at ductal adenocarcinoma tissue compared to normal, healthy pancreatic controls, looking for differentially methylated regions in tumor tissue that would distinguish cases from controls. And as you can see in the histogram on the left, that there were several markers individually at a tissue level that reached an AUC of nearly 1 or at least above 0.9. And some of these markers not only differentiated cancer from normal pancreatic tissue, but as you can see in the case of methylated TBX15, it really demarcates between the grades of dysplasia. So IPMNs with high-grade dysplasia versus low-grade, and then PANN-3s versus PANN-1 and 2. So we took this early data in tissue and embarked on a clinical pilot study. This was a 3-site Mayo study that was published a few years ago, where we took 38 biopsy-proven treatment-naive cases of pancreatic ductal adenocarcinoma, collected pancreatic juice in these cases, as well as in controls that included both patients with a normal, healthy-appearing pancreas, as well as those with cystic disease and inflammatory disease in the pancreas. And the collection of pancreatic juice, as I had mentioned previously, is a duodenal collection. So for those who are not gastroenterologists in this room, the tip of the endoscope you can see in the small bowel position, and there's a small catheter that comes out. And we can suction the fluid from the small bowel without doing any invasive cannulation of the pancreatic duct or poking a needle in the pancreas. And then this fluid collects in an endoscopy trap, and we can extract DNA from it and do the analysis that's required. So for the initial study, we used a panel of 14 methylated markers that were derived from the tissue discovery study that I just shared with you. And these were then combined in a panel using partition trees and cross-validated in silico. What we found is that there were individual markers, in this case C13ORF18 and FUR1L4, that clearly, again, discriminated cases not only from normal, healthy controls, but you can see even in the disease controls, that's kind of the middle bar there in the box plot, that there was discrimination between cancer cases from patients with pancreatitis, for example. And when we combine a few of the top performing individual markers into a panel, the AUC was 0.9. And more reassuringly, when we look at stage distributions, you look at early stage cancers and high-grade dysplasia, compared them to more advanced stage disease, there was no difference in sensitivity of detecting disease across these stages. So obviously there was more optimization that needed to be done. One of the challenges when working with pancreatic juice is that it's an enzymatically rich fluid, and that really leads to degradation of DNA quality rather rapidly, if not stabilized. We learned this in our early studies. And then we went back to the bench and did a few optimization studies. The one that was most impactful was adding buffer to the trap, DNA stabilizing buffer to the trap in the endoscopy room for juice collection. And this improved the DNA yield and allowed the DNA to stay stable at room temperature for longer. So with those optimization steps, we moved on to the next phase. This is a little schematic that we often use within our team when developing diagnostic tests. And as you can see, it goes through phases of marker discovery, marker selection, developing an algorithm, and then independent clinical validation. And what I've shared with you so far is the tissue discovery, validation, and early phase testing in pancreatic juice. With this background, we embarked on what we call the marker selection study, where the goal is to confirm and select the best candidate markers in an independent case control design. And this study was recently completed. This was a collaboration between Mayo Clinic in Rochester and Florida. And we expanded the number of cases of pancreatic cancer we had in this study. As you can see, we had 95 cancers compared to 38 in the previous study, slightly higher representation of early stage disease, as well as an expanded cohort of controls, both normal and benign and neoplastic controls as well. And it's really important to emphasize the need to include these disease controls in any kind of marker discovery experiment, because these are the patients that you'll probably see most frequently requiring a diagnostic assay. And we had a similar experimental setup for this particular study, apart from the addition of the DNA stabilization buffer. And we took the exact same panel of the 14 markers that we had studied in the previous study and assayed them in this cohort. And what we found is that the 3 methylated DNA markers that had highest individual AUCs in our previous study were identical to what we had seen previously. I'm showing here the box plots of how the marker levels for FUR1L4 and C13ORF18 were in this particular study, going from normals to cancers and across the spectrum of disease controls. And you can see a little bit of a step up, which is to be expected. And when we combine these markers, we got a cross-validated AUC of 0.87, again, fairly similar to what we had reported previously and certainly within the confidence interval of the previous study. What was exciting to see is that when we combine this with paired plasma CA19-9, despite all the good and bad things we have said about CA19-9 so far, it really seems to advance the diagnostic ability of this marker panel. And we got an AUC of 0.95, sensitivity and specificity approaching 90%. And the addition of CA19-9 outperformed both the pancreatic juice markers by themselves as well as serum CA19-9 by itself. There have been several other groups that have started to explore pancreatic juice methylation as a potential biomarker for pancreatic cancer. This is a beautiful systematic review and meta-analysis published by our Dutch colleagues. 14 studies, nearly 600 cases of cancer in all. I just want to highlight that there are very few studies that really obtain histologic confirmation of PDAC for all cases. I think this is really important early in the phase of any biomarker work, is to make sure that there's a diagnostic gold standard that's followed. And there's in general a paucity of normal controls, and a lot of studies aim to cannulate the pancreatic duct, which at least in our experience doesn't seem to be something that we would require to do. And so I'd like to summarize by saying that pancreatic juice biomarkers appear to be a promising tool for early detection of cancer. And I've shared with you the journey from tissue discovery to feasibility and prospective validation of a methylated DNA panel. There are prospective studies ongoing to assess the impact of this in the screening of high-risk individuals. And I believe that a multi-target pancreatic juice assay may enhance detection not only of early-stage cancers, but advanced dysplasia. And I'd like to thank my team at Mayo Clinic for pancreatic cancer research, my collaborators both at Mayo Clinic, Florida and Rochester campus, and Megan Engels, who was a PhD student from Professor Janine Van Hoofd's group in the Netherlands, who partnered with us on this study, and obviously acknowledge the funding support, especially from the NCI Pancreas Cancer Detection Consortium. Thank you.
Thank you. I think we have time for one question.
Hello, Mansoor Yash, NYU. Thank you for the fantastic talk. Two-parter maybe, real quick. So you had patients that were stage 3 and 4 in your PDAC cohort. I assume so they probably got some form of chemotherapy. Did you notice if that changed the specificity or sensitivity of your test in these patients? And the follow-up to that is, was there a trend in the copy number across the stages?
Yeah, that's a great question. I'll answer the first part. We did not include any treated patients for any of these studies. So these were all treatment naive patients. So, sample collected prior to initiation of treatment, often in the context of kind of a new diagnosis of cancer. And in terms of copy numbers, there is definitely a trend towards higher DNA yield overall as the stages progress, and that typically translates in a targeted assay, that typically translates to a stronger signal. Thank you.
Thank you so much.
We next have the pleasure of having Dr. Michael Goggins from Johns Hopkins University presenting his talk on the microbiome and early diagnosis of pancreatic cancer. Michael?
Thank you, Steve. Good morning, everyone. Pleasure to be here. I have no disclosures. Let's see how we move these forward. Okay. So, microbiomes and pancreatic cancer. So a big topic. We'll do a very sort of whirlwind discussion of a few recent studies. Can we use it for risk assessment? Even greater challenge in many ways than diagnostic challenges. You heard Allison's talk, and there's a significant gap in our understanding about risk. So basically, we know that microbiome is tremendously affected by all sorts of factors that really bedevil the field, whether it's diet, geography, lots of medications, changes with disease, all sorts of factors that are hard to account for in an individual patient, but are important to do so as best we can. And then, of course, microbiomes very simply influence metabolism, would they be a measure of understanding metabolism, assessing risk better? There's tremendous studies being done, particularly on its role in immunity and response to checkpoint. So what do we know about microbiome and cancer risk? Relatively few studies that have been done. For example, a nice study that used the PLCO cohort published a couple of years ago on lung cancer risk. Perhaps surprisingly, even though they found interesting, significant data in a relatively moderate-sized case prospective study, odds ratio of maybe 1.2. So, you might have thought that perhaps you'd see greater risk stratification with microbiomes, but we don't see it in these other cancers. And then what about the pancreatic cancer? Well, there's been only a few studies that have looked at prospectively what the role of the microbiome profiles might be, oral microbiome or gut microbiome. So, for example, 6 to 7 years ago, we had a study by Fanadal in gut, and they found some signals that were significant. There's been a long literature on gingivitis, for example, and some of the bacteria associated with gingivitis came through as positive, modest risk factors, so that was interesting. A more recent study that looked at the Harvard, with the Harvard group and others, didn't confirm that. That was a somewhat smaller study. So again, we're challenged here to get clear-cut answers on microbiome risk with pancreatic cancer, and so we need more studies there. This was a nice study by Johan Farman et al. From MD Anderson, multi-center study that included PLCO groups as well, about a 1 to 5 ratio of cases and controls. Again, PLCO, so prospective, close to 1,000 subjects studied overall, and looking at blood-based. So let's bypass the microbiome directly and look at maybe the metabolites that may reflect more accurately what the microbiome is doing. And so there, and combining with a few metabolites of interest, they were able to generate, for risk estimation, reasonably good risks profiles when you combine the microbial metabolites, were just, I think, 3 of them, with a few, some regular metabolites. So one of the metabolites, the microbial, was TMAO, which is a atherosclerotic methionine metabolism metabolite, which comes up as a risk factor for other diseases. So in that sense, I think it was a strong study. So there is something there, of course, to look at further in terms of metabolites associated with risk related to the microbiome, but plenty more to do in terms of risk. We've done a little bit of work on this ourselves, trying to get into the field. We have such a large cohort of patients, and predicting risk is such a challenge. And so we took the convenience sample of duodenal fluid, in this case not for all the DNA or methylated DNA, mutated DNA for assessing what the pancreas is doing directly, but what about the local microbiome environment in the duodenum, which may well affect the pancreas. And so, again, case control studies, we didn't try to do anything too ambitious. We saw differences with all the limitations of a case control study between the bacterial profiles and also the fungal profiles as well. And one of the things we were interested in is, well, just how good is this sample? You can get microbes measured in these samples most of the time, relatively low abundance, so that actually poses challenges because contamination could be a factor. But there is a decent sample. We can get a good representation. So we looked at the effect of PPIs, which kind of have a pretty reasonably well understood change. You get a greater level of some of the oral bacteria, streptococci, et cetera, for example, if you look in the stool of people who are on PPIs, and it's a reasonably strong effect. And so we see that effect in the duodenal fluid, suggesting, again, that these changes, it could be an interesting sample to collect. Obviously, you can collect oral as well. Stool is somewhat hard to collect for our patients. We wanted to look at this a little bit further, and so we looked at pancreatic tissue from patients who undergo resection for benign indications, and looked at their pancreatic tissue and also looked at their duodenal tissue. Again, challenges here, great challenges, because you are dealing with a low, many would have thought was a sterile environment until people started looking at these profiles, and there's still great concern about what's significant in terms of bacteria or fungi in these tissues. So again, we just studied the PPI effect mainly and just looked at simple head-tail differences. So for example, here we're showing that there's small but notable differences between the bacterial profile with some of the streptococcal type, oral type bacteria, a little bit more so, higher levels in the head than the body and the tail. But mainly what we're interested in seeing is, well, could we see this PPI effect? Well, PPIs have been interesting to look at in terms of cancer risk. Again, cohort studies and would raise the possibility that very hard to control for, but that it could even be a risk factor for pancreatic cancer. So we looked at whether or not we see this change and increase in oral bacteria in tissue from patients who are undergoing resection, again, for benign reasons. If they're on PPIs versus not, what's going on in the duodenal tissue now, and then what's going on in the pancreatic tissue. And essentially we see an increase in abundance, a kind of a PPI effect in the duodenal tissue. We did not see it in the pancreatic tissue. Roughly 100 patients with all the limitations. This was not a prospective study, but perhaps somewhat reassuring that we saw kind of pretty minimal changes in the pancreas. So still an area we need to further understand what's going on. And we limited our analysis to just the normal tissue, trying to get some handle on what's going on there. Switching over to diagnosis, basically, there's great interest, of course, in the diagnostic potential. This is based on a few studies. People looked this in the context of cancer, in the context of pancreatic cysts. There have been studies looking at what are the microbial profiles within cyst fluid. Are some of these IPMNs that go to surgery, are they more inflamed? And again, historically, we would have thought it was a sterile environment. And so there has been some work on this suggesting that maybe this is significant. But then what's happening with the field in recent years is we've gotten a little bit better at dealing with some of the major issues, whether it's database or figuring out what's contaminant and what's not. And so the more recent studies here are showing one from the Boston group, the Harvard group, showing that basically not much of a pancreatic microbiome within the IPMN tumors that they could say was any different to control tissues. Another paper from Peter Allen's group, similar results that's just come out. So again, that change reflects improvements in how groups are figuring out how to do these kinds of analysis, if probably more than anything else. So what about for cancer? So a couple of years ago, there were a couple of interesting case control studies which looked at whether or not a signature, fecal or oral signature, could essentially, could you diagnose cancer with a stool or oral microbial signature. So this was a European study, relatively small, especially for these kinds of studies. Spanish and German, and then a subsequent study I'll show you in a minute from Japan. And essentially what they found was a roughly 24 bacterial signature, and they developed some models for, could they predict diagnosis. They described two models. One was better than another in terms of specificity, and you're seeing here these AUCs. Excuse me, I'm getting confused with my slides. Moving on. So here's the two dozen microbes, and you're seeing on the top, and then you're seeing the AUC on the bottom. And so modest AUC performance, you might say, well, that's either glass half full or glass, not full at all, because these are cases who have gone, lots of things have happened to you once you become a pancreatic cancer case, how your pancreas is functioning, you have pancreatic insufficiency, and they try to control for a lot of these factors. So it's kind of notable that you would see even a modest difference. And from their perspective, they're trying to say, well, okay, if we take a microbial signature and then we add the tumor marker, is that going to get you to a higher enough diagnostic performance? And it was pretty good. They again, this is shotgun sequencing and identifying this, and then they applied it to other data sets of other different diseases to establish what the false positive rate was. The lower bar charts show lowish false positive rate. So interesting that there is a signature, but again, relatively small sample size for what you'd really want to see. A somewhat larger study that then from Japan and then validated with this European study as well, found broadly similar results. In this case, they looked at oral and fecal microbial profiles. Again, same idea, shotgun sequencing of microbes, come up with an interesting signature that they then try and validate, try to adjust for as many covariates as they could, which mostly didn't have too much of an effect. AUCs kind of in the close to 0.8 range. Again, these are cases. This is not prospective, risk. So we have to account for that. And then what happens when you add a tumor marker? And then below that is some of the other confounders. What if you what if you, let me see, excuse me here. And then they went and looked at other diseases as well. So what happens if you have an IPMN group versus pancreatic cancer? What happens if you have a chronic pancreatitis group, you have pancreatic cancer? Well, not surprisingly, some of those AUCs start to diminish. So, perhaps some of this effect is, for example, if you have pancreatitis, it's known that your microbiome changes. If you're malabsorbing, if you're maldigesting, you would expect that you'd have a change in your microbiome. So, and of course, so it's not surprising. What's missing here is, people who are pre-diagnostic or limited to stage 1, where some of these secondary effects, the obstructive jaundice, the diabetes, the many factors that you don't need a microbiome to tell you have pancreatic cancer when someone is having advanced disease. But again, in terms of what they're trying to do here as a first blush at this, these were interesting findings. The last area to discuss briefly is what about blood? So imagine that blood microbial DNA could potentially be diagnostically useful. This was a paper that really made a splash about 3 or 4 years ago. Pan cancer, tissues, and blood. After a splash for a couple of years ago, then there was a lot of controversy. Steven Salzberg from our institution said, well, look, lots of errors, again, taking this shotgun sequencing, applying all the reads to the available databases, and they're finding all of these microbes. Steve says, hold on, guys, the databases are wrong, there's a lot of contamination. But by that time, actually, Rob Knight et al. had the tools that we have, the database have been improved, and so they turned around and put up their own validation paper showing similar results. And this first paper was bacterial, and then they came up again with a second paper that was published actually before, over a year ago now. Fungal DNA circulating. Again, if you're interested in biology, this is fantastically interesting. And it was pan cancer, dozens of cancers, including pancreas. But again, relatively small in terms of the number of controls. Even though these guys know how to do microbial studies, you still have to wonder about what the source of this is. But for example, even taking fungal DNA specific PCRs, though, in addition to this metagenomic sequencing, amplifying fungal DNA with a specific probe in a bunch of different cancers, higher levels than in controls, is I'm trying to see if I can show you this here. And you're seeing here fungal DNA in different settings here across different cancers, including pancreatic. One challenge that's still notable is, again, similar AUC results in stage 1 disease versus stage 4 disease. So we're not kind of seeing some of the clues that would tell us that this is definitely a game changer, but I think this remains understudied and yet very interesting. Still a lot more work to do. So, in conclusion, lots of methodologic challenges to the analysis of microbial DNA. Interesting studies. We don't really fully understand what's causing all these microbial changes. You have to suspect or unaccounted diseases, the pancreatic insufficiency, the jaundice that are contributing. And so it's how early is this happening? Can it really be something that we can use for early detection? And maybe some of this could even be used for risk. So insufficient evidence, we need more studies. Thank you.
Thank you, Michael. We only have time for one quick question, and actually, because I'm the moderator, I'm going to ask it. So obviously, we have a lot of difficulty in developing assays that can perform well in early diagnosis of pancreas cancer. So do you envision adding a microbiome marker to some of the ongoing proteomic or DNA markers that are going on to improve their performance?
Yeah, I took an interest more in this for its risk. Could you risk stratify and have something that would be more stable? That the metabolic consequences when looking into this, I would say it's possible. I mentioned the blood at the end. I think if it was real, that could have diagnostic possibilities. But I'm still on the fence in terms of where I think it's very worthwhile science to prospectively do, and these need large-scale studies. But I think we have better diagnostic tools.
Okay.
Yeah. Thank you.
Thank you, Michael.
I'll introduce our next speaker, Dr. Suresh Chari, professor at MD Anderson. He'll be speaking about clinical trial design for early detection initiatives, translating tools into clinical practice.
Thank you, Yasmin and Steve. I appreciate the opportunity to speak today. I agree that speaking in this forum here with lots of people interested in early detection is indeed a pleasure. We have been attempting to develop a strategy for early detection in the sporadic cancer field, and it has come with its own challenges. I know Mimi and Mike have been working on the familial side for decades, so it's interesting to discuss the issues with how to develop something for sporadic. So we have talked a lot about what it takes. From a familial standpoint, your starting point is a patient with a family history, a subject with a family history, and that's your starting point for. But what do you do in a sporadic setting? Who do you start with? And I believe it should be a cohort with a high enough risk, and we'll go into what does high enough means. And more importantly, a high enough absolute incidence. This relative risk is a little problematic. It has to translate into absolute incidence for your cost effectiveness studies that Beechin had shown. At least by my estimates, currently screening the general population for pancreatic cancer is not feasible. I don't know. That's my feeling. I know that biomarker folks want us to go directly to the general population, but it seems like the false positives is going to be a tremendous problem. And the other big issue is the lead time between the trigger for early detection and the diagnosis of cancer. And the interesting thing is that the stronger your signal is, the closer you are to diagnosis. So you may have a very strong signal, but your lead time is very short. So you need to have enough lead time to be able to work up the cancer. And that's an important part of the understanding of when we are ready to go with it. And an imaging modality that can find the lesion. That's the other struggle we are having, is that you have the potential cases that to find, but you do the CT and it's normal. I mean, we have looked at CT scans, and as early as 6 months before the cancer, half of them are normal CTs. So we need to be able to find the lesion as well. But I don't think we have to wait for every single piece to fall into place for us to be able to start this, because there is a lot of learning to be done, even setting up a program like this. And so we have started down this road, and we are learning as we go. So our vision for early detection is that one should define a high-risk group, enrich it, and then find the lesion. So we'll talk about what each of them has a very specific bar to reach to be called a high-risk group or a very high-risk group. So, so the general population average risk, the 3-year risk is 0.12%. So that's your starting point. And what should a high-risk group be? Beechin had shown the cost-effectiveness data on what that is, and that's what we are basing it on. It should have a 3-year incidence of 0.8% somewhere, which is what Beechin had shown in the cost-effectiveness studies to be cost-effective to screen. And so that translates into 6 to 8-fold higher risk compared to the general population. And that's what, high-risk groups are used loosely. Anything which has a p-value is called a high-risk group, but that's not helpful for us. An actionable high-risk group, according to me, is something that has that kind of a 3-year incidence. And we talk about 3-year incidence because we are looking at new onset diabetes, and there's a very defined time frame in which that cancer occurs, and after that, it's average risk. And a very high risk group, if you want to, it's 25x or 2.5%. Beechen had mentioned 10% positive predictive value. I believe we are setting up pancreatic cancer for a way higher bar than any other cancer that we are looking for. Colon cancer doesn't have a 10% for a colonoscopy. Lung cancer doesn't have 10%. It has 0.3% for 20 pack year history. Why are we setting up ourselves for such a high bar? It's unfair, and I do not believe that should be the way we should be going. There are steps as we go down that will lead to that yield, but I don't know you want to have a 10% yield before you'll do an EUS. I won't accept that. I mean, why are we having ourselves being put to a different bar compared to lung cancer or colon when you have a group that has the same risk as lung cancer? So it seems to me to be unfair. So then the finding the lesion is the hardest part, which also needs work, because at this point we may have the group, but we don't have the necessary ability to find the lesion. So we have been looking at high-risk group as the glycemically defined new onset diabetes, and we have shown that the glucose rises with time, and all this happens within the 3 years before the diagnosis, so it's a 3-year risk we're looking at. So this is the study that we just presented yesterday, where we looked at 18,000 subjects with glycemically defined new onset diabetes. And this is the standardized incidence ratio, and you'll see that in the non-Hispanic whites, it reaches that bar 6.4-fold. In Hispanics and African Americans and Asians, it's lower, but we can go into discussion about why it's lower, but I think it can be mitigated as well and brought to the same yield as the others. If you look at the absolute 3-year incidence of pancreatic cancer in these cohorts, in whites it's 0.84%. In Hispanics, it's 0.4, and in African Americans, 0.37. It is lower in these groups, but there is much more to the story than these numbers tell you. 50%, their median age of onset of diabetes in blacks and African and Hispanics is significantly lower than in whites. So you see 50% of the Hispanics being in the 50 to 59 age group where the risk of pancreatic cancer is lower. So there may be ways to mitigate this, but there is definite racial ethnic difference in risk. This is a lead time distribution in the 83 cases that were seen in that cohort. And when we do the Kaplan-Meier estimates for a 3-year lead time distribution, 70% have more than 4 months of lead time, which I think is, we call it clinically meaningful lead time, because if you have that, you should be able to clearly show stage shift. The median lead time is 7 months, and 60% will occur within 1 year. So there is a certain urgency to working this up, but if you do work it up promptly, there is significant potential for stage shift and earlier detection. And we have used the NPAC score before, and it does double the risk of pancreatic cancer in this cohort. Certainly, there are numerous biomarkers in the market, and they could do a better job than that, and whatever works. But one thing that this did, at least in the Mayo study, was it identified 50% of patients as having type 2 diabetes with extremely low risk of pancreatic cancer. So it at least reduced the number of people that needed to be worked up. So if it holds up in subsequent studies, that would be useful from that matter. So this is what it does. It takes a group that has a low risk to a high risk group and a very high risk group, and at that point you can do further testing. So this is what the early detection initiative is based on. You take patients with new onset diabetes and you randomize them before you have calculated the NPAC score. And once you have the experimental arm, you calculate the NPAC score, and those who have a high NPAC score get imaging done. So this is the schema of the early detection initiative. one of the biggest struggles we have in these studies is patient consent and the timely workup of the patients. And this continues to remain a challenge for EDI as well. So our primary goal here is to determine if this algorithm-based screening in new onset diabetes results in earlier detection of PDAC as evidenced by a lower proportion of stage 3-4 disease at PDAC diagnosis. Again, stage shift is much easier to show than survival difference, and that will take a much larger group and a much longer follow-up. So our initial step was to show that there is ability to show a stage shift with this approach. So our vision has been to start with the general population, identify a high-risk group, apply the impact score, and do CT imaging. This is the original EDI, and as more data comes through from other ways of enriching cohorts, we can certainly substitute or add to whatever is there. But this is the current setup of the EDI vision. I'll stop here and take questions. Hopefully I've given you back some time.
Thank you. You did. We're happy to take questions.
Thank you, Dr. Cherry. For the lead time, which seems to be kind of an important metric when designing these things, is it different for NOD with high impact versus the low to normal impact score?
Good question. I don't think so, but would have to do the same thing with the high impact score group. But I don't think the impact score is higher in patients who are closer to diagnosis, but they already have crossed the bar. So all patients, regardless of whether their NOD was 2.5 years ago or 2 months ago, have already crossed the bar for being qualified for the EDI study. It's just that the score may be 2 or 2.5 or 3 versus 10, but 2 is the bar. So I don't think that it'll matter, but we haven't looked at it that way.
Okay. Just the comment on the bar, I mean, one of the things about lung cancers is it's easy to do a CT scan and find a nodule.
We would like to do the same with CT of the pancreas.
But I think that's the challenge with the pancreas.
No, I
finding
understand
those small
that, but to say that the bar should be 10%, otherwise I won't even start,
Right.
is you will never start.
No,
I'm saying we
I
will do
completely agree.
AI-assisted CT and detect the cancer early and get rid of this concern that we cannot find the lesion. As long as you cannot find the lesion, there's no point in even starting.
That's the key aspect. I completely agree with that.
Yeah.
That's finding the lesion. Imaging has yet to, we talk about the biomarkers, we talk about the way of strategies like the EDI, but the CT portion of that is not where it needs to be, and neither is the EUS probably, and that's where we need to improve. So are we really at the time of doing an initiative when we don't have the technology to actually...
I disagree that we have to have all the pieces in place before we start. That will set us back. Because what we are learning setting up the EDI is there is so much to learn about setting up the EDI that if you start to do only after I have my best CT scan and the best PET scan and the best biomarker, I won't start anything before that, we'll be behind. There's so much to learn even setting up this process. So I think that we are learning as we go, so there's no harm in doing all this in parallel as opposed to in series.
So we'll only have one more question, but please everyone stay, and please stay, because I think
That's
everyone's
too bad.
disappointed
Yeah.
to not ask their questions.
So just clarification, I think the 10% PPV would be ideal, and anywhere...
It's not ideal,
we're at
it's too
1%.
much.
We're at 1%
It'll kill the program.
Well, I don't think it stops us from moving forward. That's the question. But the question I have, and we've talked about this, Suresh, and I think for the benefit of the audience, though, why the racial ethnic differences in terms of the not associated risk of pancreatic cancer?
Okay, I'll spend 30 seconds on this because this is worthy of a larger discussion. So what we found was the age of onset of diabetes in Hispanics and African Americans was significantly lower than in whites. This is well known in the diabetes literature, but we were dramatically confronted with this when we saw the data. So the question is this risk shifting from new onset diabetes to long-standing diabetes in patients with Hispanics and African Americans? They already have diabetes for a few years. Now they're getting cancer. Their newer long-standing diabetes is getting worse, so their risk of cancer in long-standing diabetes may be higher than in the whites. I don't know that. But the other thing I know is that if the bar is, we looked at healthcare utilization. Their number of visits to the hospital was the same. Their number of blood sugars they had drawn were the same. There was no difference between whites and Hispanics in terms of healthcare utilization, so that was not the answer. If there is a biological difference between Hispanics and African Americans and whites in terms of the cancer they get and the diabetic potential of that cancer, I do not know. And our study cannot answer that because we don't have all the cancers and all the patients in there. So it's worthy of further study and further discussion, but it clearly is a dramatic finding in our study. Beechin found it first in a large retrospective study, and we are just validating what he found earlier. But certainly is something we'll have to confront as we go forward. So.
Thank you.
So we now have two shorter presentations that were selected from high-impact abstracts. The first one is presented by Eileen Carpenter, and the title of her project or her presentation is an analysis of normal, healthy human pancreas finds neoplastic lesions with unique microenvironments. Please.
Thank you. I think we have like 2 minutes for 2 talks, so I'll try and keep it brief. I have no relevant disclosures. Back in 2000, so we have a very robust organ transplant program at the University of Michigan, but back in 2007, we sent a transplant team of 2 transplant surgeons and 3 transplant specialists. We flew them out to Milwaukee to procure a set of lungs for transplant, and on the way back, they tragically crashed in a jet crash, and the organ and the entire team died. And so at that point, we redesigned our organ procurement program at Michigan to instead transport donors rather than actual medical teams to local procurement facilities, and then the organs would be harvested close to our hospital. And so in collaboration with Gift of Life Michigan, Doctors Marina Pascadmagliano, Tim Frankel, and myself collaborated in order to use these donor organs that would otherwise be discarded to do deep molecular profiling on the pancreas prior to the development of any pancreatic disease. And so the pipeline starts with a phone call from Gift of Life to our lab, and once we're made aware that an organ is made available, they cross-clamp the superior mesenteric arteries, celiac artery, harvest the organ, and then deliver it on site. The procurement facility is next to Costco, which is 10 minutes from the University of Michigan, if any of you know what Costco is. The most important thing about this is there is no warm ischemic time for these organs. And so this is an example of what a donor pancreas looks like. When it gets into our lab, we have 2 surgeon scientists dissect it into head, body, and tail. And then we then have a flurry of activity, and several team members process this tissue for histology and multiplex immunohistochemistry, single-cell RNA sequencing, immune cell processing, and we also make normal pancreatic organoids. Now, I mentioned that there is virtually no warm ischemic time. That is only the case for donation after brain death. So donation after cardiac death is a different situation where the patient is taken off of life support and the heart and lungs are allowed to stop for anywhere from 30 to 90 minutes. And so we actually looked at one of these organs, and you can see just with 30 minutes of warm ischemic time what happens to the pancreas, and a very stark difference in pancreatic cell viability. So with that being said, we chose to only use DBD organs going forward. And so for our initial cohort, we looked at 30 donor organs, a good mix of male and female. I want to point out that a third of our cohort is from Black Americans, which historically has been underrepresented in molecular profiling studies in pancreatic cancer. And together with our GI pathologist, Jackie Shee, we are able to identify all expected structures, normal acinar cells, acinar ductal metaplasia, normal ducts, and surprisingly, Pannin lesions. And so when we break this up by age, we actually found that Pannin lesions, scarily enough, were quite common even in donors in their 20s. And so here's another set of H&Es. Each H&E represents one donor, and we found many Pannin lesions, actually, but they were rare, meaning that we would have to go through quite a bit of the pancreas just to find one lesion. I will say that most of the lesions that we found were low-grade Pannins, and right now we're up to 70 organs that we've collected, and in all those 70, we only found one high-grade Pannin. And so with our multiplex immunohistochemistry, we actually see that we get a whole variety of macrophages, T cells, and fibroblasts that surround these pannins. So there is a very abundant stroma around these pannins. But we wanted to look further into what those cells were and how they were different from actual tumors. So we have a very large single-cell pancreatic tumor data set at Michigan, and so we compared these stromal cells, the macrophages and the fibroblasts, to actual pancreatic cancer, and we actually found that there was quite a good separation. So the green is, each green dot represents a donor sample, single-cell sequencing sample, and the blue is the tumor, a tumor single-cell sequencing sample, and we threw in a couple adjacent normal. So these were adjacent normal tissues from resections of patients who had pancreatic cancer. And you can see that there is a very good separation transcriptomically in the myeloid cells. And you can also see that adjacent normal tissue, which historically has been the comparator for these molecular profiling studies, is not normal at all. And the same is true for the fibroblasts. So we do get a very good separation of healthy fibroblasts from cancer-associated fibroblasts. Now, when we wanted to look at the epithelial population, what is different about the epithelial cells in pannins from tumors, we had difficulty. And the reason is because pannins are exceedingly rare, but present in the pancreas. And so when we looked at our single-cell sequencing, which does not preserve spatial data, we could not figure out which of these healthy epithelial cells belonged to the pannins. And so for that, we turned to spatial transcriptomics, where we actually took sections that we knew had pannins from our Gift of Life tissue, and we painted the cells with pancytokeratin, which makes the pannins light up quite well. And we captured regions of interest of acinar cells, acinar ductal metaplasia, normal ducts, and pannins. And we also included tumor tissue for a comparison so we could compare pannins to tumor. And so when we mapped the data that we extracted from our spatial nanostring, we found a signature for acinar cells, which lit up these cells to the right. We found a signature for the tumor cells, which lit up these cells to the left. And surprisingly, the pannin transcripts also highlighted the tumor cells, meaning that transcriptomically, pannins from healthy donors transcriptomically resemble tumor cells. And so in summary, not to give you all dyspepsia before lunchtime, but pannins are very common. We all probably have them, even the ones without gray hair in this room. And the microenvironment of these pannins are very distinct from tumors, but the pannin cells themselves are very similar to tumor cells. And so that brings up the question, why do some progress to cancer while most do not? That also makes us, keep in mind that, and I appreciate that everyone's trying to, use US to identify Pannin lesions, but the presence of a low-grade Pannin lesion should not automatically make you think that patient's already in a higher category, because we all have them. And so I think it'll be really important to identify the features and drivers of progression from low-grade Pannin to tumor, and that'll be really instrumental in identifying early stage markers and potentially early intervention. Thank you.
Thank you. That was very provocative. Mimi,
Yeah,
one question?
Yes, sure. Very nice work. So I calculated what you said, one high-grade Pannin in 70.
Yes, in our cohort.
That's your prevalence. Okay, and
Yes.
for the regular Pannins, like all comers, and maybe I missed it, was it age stratified so that you have like a prevalence by age group?
Yeah, so that's a great question. The problem is for the first 40 patients that we did not red loaf the pancreas and H&E stain like every 10, because we were doing a lot of other things with it. So we probably only histologically examined 30% of the pancreas. So our reported findings are probably an underestimate. That being said, even in the patients in the 20 to 30 years age category, it's about 30% from our undersampled.
For Pannin 1, 2.
Our low-grade
And is
Pannin,
it
right?
dog-
Pannin 1, 2 is not a thing anymore, right? It's
Sorry,
for the
low-grade,
pathologist, right?
low-grade. Sorry. But in over 50-year-old people, it doubles or triples? Or?
Actually, that is right. That being said, we don't actually have too many people at the later age spectrum, and the reason is because these are donor patients. So if they're too old, they don't actually get considered for organ procurement. So there is some limitations to using only organ donors for this. Thank you.
Suresh, could you ask the question to Dr. Carpenter a little bit later, because we're running behind?
Okay, so I'd like to introduce, thank you so much. So I'd like to introduce our next speaker, Dr. Lawrence Janssens, who is a third-year GI fellow at the Mayo Clinic. He'll be speaking about predictors of pancreatic imaging abnormalities and concordance between EUS and MRI for pancreatic cancer screening in high-risk individuals.
Yes, thank you, and thank you all for sticking around. Okay. So my name is Lawrence Janssens. I'm trying to find the mouse. Is it?
You can see it there.
Oh, it's there.
His talk is not selecting. Would you be able to bring it up?
I think the computer knows we're out of time.
It decided to cut you off. No,
Yeah.
it's not going to do it. We're going to let you go. Can you give your talk without the slides?
Without the slides. It's a fairly visual talk. I can try.
Maybe kind of start. And
Yeah.
then,
So I'll be talking about patients undergoing a high-risk pancreatic screening program and looking at concordance between EUS and MRI done for the purposes of screening. The benefit of being the last one is that, a lot of speakers have already mentioned high-risk screening, and so as Dr. Wu pointed out, high-risk screening for pancreas cancer is not recommended in high-risk individuals. There we go. Thank you. So, and now hopefully the slides will advance. There we go. So high risk, not recommended in the general population, only in certain high-risk individuals based on pathogenic germline mutations and or a family history. In terms of what to use for screening, the recent 2020 AGA practice update recommends using endoscopic ultrasound and MRI in combination. How concordant these modalities truly are is a little bit unknown, and we also don't have a lot of information about what the baseline imaging abnormalities are in these patients undergoing their first screening exam. So to answer some of these questions, Dr. Majender in Rochester started the Mayo Clinic High-Risk Pancreas Registry, which is a prospective registry that was started a couple of years back and has been linked to a large database of imaging information, biospecimens, including the pancreatic juice that you've heard about, and then clinical and laboratory data. Currently, we've accrued about 235 patients, but at the time of this study, we had less patients, so that's why you'll see some lower numbers. And the objectives of our study now were to identify predictors of abnormal pancreatic imaging on the index scan, and to look at the concordance between pancreatic cystic and solid lesions on EUS and MRI. So to do so, we looked at the first 100 high-risk individuals that were that enrolled in our prospective registry that had a baseline EUS and or MRI. Again, HRI defined by the AGA clinical practice update. And we defined abnormal pancreas as having either features of chronic pancreatitis, presence of cysts with or without worrisome or high-risk features, and then solid lesions. And of these 100 high-risk individuals, we had 70 that had a paired MRI and EUS at their baseline screening exam. So the median time between the two was only 2 days. And there we used Cohen's kappa to look at concordance. So I think the first striking finding that we found is that half of the patients that underwent an MRI had a quote-unquote abnormal pancreas on the initial baseline screening exam. And that number, maybe not surprising for the sonographers in the room, increased to 84% on EUS. And here you can see a forest plot where we looked at different demographic variables and whether or not they were associated with abnormal imaging findings on both modalities. And I'll point out that increasing age on the patients undergoing MRI was the only factor significantly associated with the finding of abnormal pancreatic findings on the index scan. As you can see on the EUS side, the confidence interval is a little bit more broad, and that's probably because there were so many abnormal pancreatic findings on the EUS. Next, we looked at the concordance between the two modalities. And so this is the 70 patients that underwent both MRI and EUS. And as you can see, for most of the patients, when there was no cystic lesion, and I should specify this is only looking at cystic lesions, the patients that did not have a cystic lesion on EUS also did not have one on MRI, and then those that had cysts without worrisome or high-risk features on EUS had the same cyst without high-risk or worrisome features on MRI. And then you can see there were 2 patients that had worrisome features on both EUS and MRI, and those were actually related to a dilated pancreatic duct, so those lesions were not sampled, but they were surveilled. There were 7 patients that had non-worrisome cysts on EUS that were not noted on the MRI, and then there were vice versa 3 that had non-worrisome cysts on MRI that were not seen on EUS. And then most interestingly, there were 3 patients that were found to have worrisome or high-risk features on cysts noted on EUS that were not reported as worrisome or high-risk on MRI. Of those 3, after we looked through clinical reports, 1 could not be confirmed to be a high-risk or worrisome cyst, but the other 2 are shown here, and that's why I was hoping to get the slides, because there's a little bit of images here. I'm not sure if you can see the grayscale, but essentially the cystic lesion that was noted on MRI and deemed not worrisome was found to have a thickened irregular cyst wall on EUS, and both were found to be low-grade neuroendocrine tumors. Then looking at the solid masses, not surprisingly, the overwhelming majority of the patients did not have a solid mass on either modality, so 95%. But there were 2 patients that had a mass on both EUS and MRI. One of those was a pancreatic adenocarcinoma. The other one was actually found to be a splenial. And then there were these 2 patients that also had a mass noted on EUS, not seen on MRI. Again, found to be low-grade neuroendocrine tumors. So, in conclusion, increasing age was significantly associated with pancreatic imaging abnormalities on index MRI skin in high-risk individuals undergoing pancreatic cancer screening. And we frequently identified cystic lesions, but most of those were non-worrisome. And we also found a moderately high agreement between MRI and EUS for focal pancreatic lesions on the index screening exam. And when the results were discordant, it was usually related to either non-worrisome cysts or low-grade neuroendocrine tumors. And with that, I'd like to thank you for your attention and patience.
After these questions, also any speakers that could come up so that the audience who did not have their questions answered can ask them, that would be great. Go ahead, please.
Hi, Louise Wang from Yale. Great talk, and it's great that you're doing this as in fellowship. I had a question about how you defined your high-risk population in the beginning. You had mentioned that some of these individuals had chronic pancreatitis. So did they have a baseline image, such as a CT scan, even before this MRI and EUS? And if so, what was the timing of that baseline image with this?
Yeah, it's a great question. So the high-risk individual, I had an extra slide here that I hid, but it's essentially purely based on the germline mutation and the family history. So that defined the high-risk individual. After then, they had their initial baseline imaging exam. Then we defined an abnormal pancreas based on the features of chronic pancreatitis, presence of cysts. So the imaging abnormalities were not related to constituting a high-risk individual. That was purely based on mutation status and family history.
And I'll say the only other thing is it would be interesting to kind of use AI to look at the discordant features between the MRI as well as the EUS to see, maybe there's something that the radiologist I cannot see too.
Right, yeah, I totally agree. Thank you.
So just a comment, I thought that was a really nice finding of the neuroendocrine tumors, because those cystic neuroendocrine tumors are actually notoriously challenging to diagnose, especially with just conventional cytopathology. And so that is something that we've seen as well, that we get a lot of misdiagnosed cystic neuroendocrine tumors, but you pick up on molecular analysis.
Right, yeah, thank you.
Thank you.
So we're going to bring the meeting to a close. Thank you, Yasmin, for being co-moderator with me today. Also, I think one thing we picked up from several of the speakers is this type of session should be continued every year because of the importance of the topic of early diagnosis, prediction, maybe even ultimately prevention. So we will tell the organizers. Thank you so much.